Hi, my name is Ziv Peled. I'm a plastic surgeon by training, having finished my plastic surgical training at Harvard in Boston. And I practiced in San Francisco. Following my plastic surgery training, I actually did a year of peripheral nerve surgery fellowship and peripheral nerve surgery, and a lot of the chronic pain that ensues as a result of patients with nerve injuries is the main focus of my practice, which is about 90 to 95% of what I do now. So I started off as a plastic surgeon and did all the general plastic surgical things that you think about: craniofacial reconstruction, finger and hand injuries, a lot of flaps and grafts for reconstruction and so forth. But what I realized after a while with my peripheral nerve surgery training background is that there's a huge need and a real niche for patients with chronic nerve pain. I think for so long, and I think to a large degree still today, we don't have a lot of great answers for these people, although we're learning a lot and can provide certainly a lot more now than we could even just a few years ago. And I think one of the great things about being at a conference like this and incorporating fat, as we'll talk about, I'm sure, very soon, into my practice is it's yet another adjunct to help us achieve the results we're really looking for in these patients in terms of pain relief. It's actually a relatively new thing for me, which is to say the last few years. I've been in practice for about 16 years in San Francisco. We had talked about, of course, being a plastic surgeon, was aware of fat, and a lot of it we used for breast reconstruction in patients who'd had radiation. And what was really most interesting to me for a very long time, but again followed from afar, is the fact that a lot of those patients who had the fat grafting to restore breast volume, there were a lot of anecdotal reports initially and then more scientifically about the fact that a lot of the radiation damage that you typically see in the skin of those patients actually also got better. And as I continued to follow the science behind this, it really just began to explode with a lot of really interesting, both in vitro, meaning in a test tube in a lab sort of thing, as well as in rat in vivo animal models, explaining the process behind these clinical findings that we were seeing. And once we had enough of a background there, I really started to think about and then ultimately added fat grafting to my practice. Fat grafting was initially done predominantly in the operating room when I started. I think anytime you try to do something that's relatively new for you, you always do it conservatively. We weren't never really sure how much pain or discomfort these patients would have post-op and how they would tolerate the actual physical procedure itself. But even within the operating room, we had gone from a general anesthesia to a sedation, and then within a local controlled, very light oral sedation in the operating room, and a good amount of local, which is a big trend in outpatient, certainly plastic surgical procedures. We found that these patients actually tolerated these operations very well. And so I've actually transitioned to doing a number of these fat grafting cases even in my office under local only, and properly placed and with enough time to allow the local to work, as well as changes in our technique in terms of how we harvest the fat, which is much more gentle, I believe, because, of course, in my case, we're not actually just taking the fat, like in many aesthetic cases, and then discarding it. We're actually going to use it and replace it into the patient. People have done extremely well, and they love the fact that they can literally walk out of the office completely lucid and honestly go back to their job in many cases. It's really interesting the way the patients know that things are working in my fat grafting for nerve patient population is that shortly after a little bit of the discomfort and soreness from the actual procedure, which includes harvesting, placing the fat where it needs to go, their symptoms seem to sort of just melt away after a while. And a lot of them will have a certain degree of nerve-like pain, which has many characteristics, but that never seems to return in those patients. So while it certainly is not everyone, they have a little bit of surgical site soreness. Again, very tolerable, usually manageable just with over-the-counter ibuprofen and Tylenol in many cases. And once that soreness fades away, which is usually a few days or a week in some cases, what they find is that the pain that they presented with is gone. And that's how they really know that things are working. My pure reconstructive surgery has kind of taken a little bit of a backseat, although with my wife I developed an operation to restore sensation in patients undergoing mastectomy and implant-based breast reconstruction, because most of those women unfortunately remain numb after that type of surgery, but are no longer. So that is the bulk of my reconstructive work. However, these are the patients, I often say when I lecture to students, this peripheral nerve world, especially now with adjuncts like fat grafting, is really a blue ocean in plastic surgery. There's so much opportunity and such a huge need because, as I just spoke about in my lecture, chronic neuropathic pain affects anywhere from 7 to 10% of the world's population. It's almost 700 million people worldwide. And I've had a number of nice aesthetic results, and those patients are happy. I've replanted a few digits in my younger years. I've done a lot of facial fractures, but the happiest patients by far are the nerve patients, because you literally make their lives better and more fulfilling. They, I think, really appreciate so much of their lives when they no longer suffer from this horrible pain that they come to your office with. And those are the letters that you get around holiday time. That's the occasional box of chocolates or wine that you get. And I'm not a huge wine drinker, but I certainly appreciate the effort. And that's really the good stuff in medicine, I think. It's pretty remarkable. Really, these patients, they are different people when they walk into the office enough time post-surgically. And when you talk to them initially, when I first started, I remember talking to them about all of the metrics of pain, for example, how much pain on a scale of 1 to 10, how often, how long does it last, describe it, it's burning, it's tingling, it feels like pressure. Now, what we end up talking about are all of the other things that you enjoy, which I think is really what people connect with. I'm a better husband, I'm a better wife, I am a better mother or father, I can ride my bike, which I just used to love to do, I can drink coffee, or just go for a walk, or be in a movie theater hearing loud noises, watching the new Mission Impossible and not having to put noise-canceling headphones on. So these people really have wonderful lives, and our success rates, especially with the addition of things like fat grafting using the tulip system, just keeps getting better and better. And so the already good results that we're seeing are even more profound and can be done with less trauma from a surgical standpoint and less manipulation in the operating room, which is always the goal. So these patients now do even better with the whole experience.